Welcome to Emergency Insights. I'm your host, James Carter. Today, we're exploring an unusual but clinically significant complication encountered in interventional spine procedures, pulmonary cement embolism, or PCE. This is an issue that emergency and critical care providers should be aware of, especially in patients with recent vertebral augmentation. Pulmonary cement embolism occurs after percutaneous vertebroplasty, a procedure where polymethyl methacrylate bone cement is injected into a fractured vertebra. This technique is used to reduce pain and restore structural stability. However, during the process, cement can sometimes leak into the paravertebral venous system. From there, it may migrate into the pulmonary circulation, forming emboli. Although this sounds alarming, most cases of PCE are asymptomatic and discovered incidentally on post-procedural imaging. That said, the reported incidence varies widely in the literature, and some studies suggest that radiographic evidence of cement emboli may be found in a significant number of patients. However, clinically significant cases, meaning symptomatic, are much less common. Severe or even fatal cases, while rare, have been reported, particularly in scenarios involving large volume cement use or extensive leakage into the heart or central pulmonary arteries. Now, let's talk about risk factors. Patients undergoing vertebroplasty are at increased risk for PCE when there's marked cement leakage into the paravertebral venous plexus. The risk also rises with multiple vertebral levels treated and potentially with the use of low-viscosity cement. These variables may facilitate easier migration of the cement into the systemic venous circulation. So, how might a symptomatic patient present? While most are asymptomatic, symptomatic PCE can manifest acutely. You may encounter patients with sudden onset dyspnea, tachypnea, chest pain, cough, hemoptysis, or even signs of hypoxia like cyanosis. Tachycardia is common, and in rare circumstances, symptoms may progress to include dizziness or diaphoresis. Long-term sequelae, such as persistent pulmonary hypertension, though extremely rare, are also possible. Now, let's move on to management. Currently, there are no standardized treatment guidelines specific to pulmonary cement embolism. For asymptomatic patients, no intervention is generally necessary. In symptomatic patients, particularly when the cement is centrally located, management becomes more controversial. Some reports advocate for anticoagulation following standard pulmonary embolism protocols, but the evidence remains inconclusive. The core issue is that cement is inorganic and non-thrombotic, making the utility of anticoagulation or thrombolysis uncertain. Supportive care remains the cornerstone of treatment in symptomatic cases. Oxygen supplementation and monitoring are essential. In particularly severe cases, where there's significant hemodynamic compromise, interventional or surgical removal of the embolus has been attempted, though these are isolated and highly selective scenarios. In summary, pulmonary cement embolism is a rare but important complication to recognize, especially in patients with recent vertebral augmentation. Most cases require no treatment beyond monitoring, but awareness is crucial because when symptoms do occur, they can mimic classic pulmonary embolism and may be life-threatening. Given the absence of formal guidelines, individualized management based on symptom severity and embolus location is currently the best approach. Thanks for joining me on Emergency Insights. I'm James Carter. Stay alert, stay informed, and as always, take care of your patients and yourselves.